Hello, listeners. What you are about to hear is a series that I've been working on for quite some time, and I've taken great care in every aspect of it because it's centered around a very serious topic, diabetic ketoacidosis, or DKA. But we know that by openly discussing serious topics, we can take some of the fear away from them, learn about them, and hopefully improve the way that we deal with them. Name it to tame it. So this is a 5-part series where we discuss diabetic ketoacidosis. It is sponsored by Abbott. The views expressed should not be used for medical diagnosis or treatment or as a substitute for professional medical advice. Individual symptoms, situations, and circumstances may vary. The series is in our podcast feed as well as on YouTube, Instagram, and TikTok. I hope you find it informative, entertaining, and I hope it helps you understand a little bit more about DKA, its causes, and what you can do to make sure you're ready in a DKA situation. Enjoy. Hello and welcome back to another episode of Diabetics Doing Things. We're telling the amazing stories of people with diabetes from all over the world. This is part 3 of our DKA awareness series, and Dr. Eden Miller is here to discuss the strategies to help prevent and treat DKA. Dr. Miller, thank you again so much for giving your time and expertise and experience to Diabetics Doing Things for this series. We're going to get tactical in this, in how to prevent and treat diabetic ketoacidosis. So we've talked a little bit about what DKA is. We talked about different examples of DKA with euglycemic DKA in episodes 1 and 2. So now for our listeners who are like, all right, I've got the information that I need. What can I do? What can I take into my practice with diabetes to prevent and treat DKA? So what would you recommend as we are preparing for our life with diabetes? What can our listeners do to help prevent DKA?
That's great. I think top of line is knowledge, right? Knowledge is power. It's meant to facilitate. It's meant to assist you, not to, scare you. It's meant to give you an action plan, right? Because it's a risk that you and I inherently have, even though we don't deserve it or anything like that, but we can actually be ahead of it. And so I think that's the first thing. So awareness is 50% of the problem, right? A job begun is half done. So I think that with those different episodes, you're going to get a great foundation. I think now what we do, now that we know, we got to put it into action, right? The diabetes keto action plan. And so what's the first thing? Make sure that you have a way to monitor, right? We got to monitor. Okay, now you know, and then we got to monitor. Now, in your monitoring, you're going to have to talk to your clinician. You're either going to decide to do the urine or the finger stick testing. We talked about that in the early episodes. We know there are benefits to one versus the other, but hey, just do something. Then what I want you to do is learn you. Like maybe, Rob, you could tell us later, what did you learn? Did you learn that you were doing ketones in areas that you never knew? Because if you don't know, how are you going to know if they're elevated? And so what I like to do, just like I did with CGM, is I say, tell me your journey. Tell me your glucose journey. I want to know your ketone journey. Not only I'll be neurotic and peeing and poking so much, but do it when you have those signs and symptoms we talked about. So then you can tell me your ketosis story, because you have a ketosis story that probably we don't know. I got a ketosis story that I don't even know. Was I spilling ketones in levels that I was like scenarios or circumstances or signs? And so could I actually learn myself and then share that conversation with your clinician? Just like they give you a tool and then you come back and you go, I want to tell you what I learned. This is what I learned. I was spilling ketones when my pump or this or that kind of thing. So then once you have that little checklist, then it's like, talk to the clinician about the action plan. Okay.
Right.
And that action plan is going to be individualized and customizable based on what your health clinician is. And I'm sure it's going to deal with thresholds or levels. We talked about that. Calling and communication, because that's always imperative. You still, because you and I own our own disease, troubleshooting, right? What do we got? What are going on? What are our scenarios? Is anything reversible? Can we attend to it? Make sure there's hydration. I would never tell people by any means not to hydrate, and then call your clinician and then go to the next step as they advise you.
All great advice. And I think it all starts with something that I'm going to be putting into practice after this series, which is just ruling out ketones, yes or no. know. And by doing that, identifying our, like, whether it's the urine strip or whether it's the blood test, making sure that, you know the signs of that ketone story, like you said, that all of our ketone stories are going to be different. Knowing what chapter 1 looks like is a really great way to make sure we're doing the right things. And also doing that in tandem with your care team, with your healthcare provider. So the entire impetus for this series is by defining and learning about challenging topics or scary topics. We can take the power away from them, arm ourselves with information, and give ourselves a plan of action. Like we've talked about in the previous episodes, we're rowing this boat, we're flying this plane of life with diabetes, and we're making these decisions on our own, and we're keeping ourselves alive and doing a great job of it. But when we talk about DKA, it's a scary topic and often, I think, taboo sometimes because of how scary it is, because it is a leading cause of death for T1Ds under the age of 58. And one of the most common, or the most common, hyperglycemic emergency. And so I guess for you, like when you're approaching a conversation with a patient and you want to talk about DKA, how do you balance that very serious discussion, life or death type situation, while still making it accessible and able to put a plan into action?
You've already told that the last 2 episodes, I'm the queen of analogies, and I use analogies because they tell a different story that we're used to. DK, diabetic ketoacidosis, unbridled wildfire metabolism of fat, being acid into our blood. Not good, right? We all know nobody thinks acid in the blood is good. All the metabolic problems, leading cause of death. Oh my gosh, right? Not only am I sweet, I'm also acidic, right? No. And so I use an analogy, and here is what I say to them. Do you know what the leading cause of worldwide deaths based on tragedy is? It's water. And it's flood. And, they all go, Dr. Miller, it's like you're putting it out of context. Yeah, flood, it can happen very fast, right? You could not be aware of it or in tune to warnings or things. You could not leave. I mean, we won't go into that. But it also, if you know how to swim, or if you have a life jacket or a life preserver, those things, you can possibly have a different outcome. So here's what I tell them. DKA, in its wildfire standpoint, not good. I never want you to get there. I never want you to get there. So let's talk about all the steps that occur before you get there, right? It's kind of like hypoglycemia. We talk about hypoglycemia. We're so great with it. We're like, yeah, I got my CGM. Yeah, I got this. No big deal. I know how to do it. I know what it feels like. I don't always feel it, but we feel very equipped. And that's on that end, right, of the diabetes spectrum. Yes, we still have fears with it, but way different with technology, way different with the tools. Now we have that on the other end of the spectrum, the hyperglycemic, or don't always just assume hyper, right? We did that in episode 2 of what we call a mismatch or a ketosis prone scenarios. And so let's fill in all of those steps to DKA. Let's look at that both from an individualized, a group, the knowledge to say, tell me your ketosis story, because this doesn't have to be scary. Just like watching the weather, looking for the rising rain, having the life jacket. There are so many different steps that we can totally empower you to detect, derail, and avoid diabetic ketoacidosis, because it's totally preventable. And so we don't want you to feel victim, like it comes just right out of left field and knocks you over. No, we got a lot more to talk about, a lot more to detect, and a lot of tools that we can empower us to be our healthiest selves.
I really like the way that you frame that, because I think not only does it resonate for me from like how fast it can turn from very normal to extremely dangerous, but also just the sort of psychological framing of like, oh, this is not going to happen to me. We don't walk around every day thinking that a large fire or flood is going to come across us unexpectedly, right? And I think it's similar, at least my experience on the diabetes management side, is I don't often think about in my day-to-day life with diabetes preventing or taking action on diabetic ketoacidosis. And I think that's something that I'm taking away from the series that we've done, is that having a measure and a method to know what my ketone story is going to let me know to wear my life jacket, so to speak, if we're going to continue the metaphor of a flood, or to know when to call the fire department if the fire starts to get out of control. And it seems like knowing when to check for ketones is going to vary for many people, but when you're feeling a little sick or unwell, when you've had high glucose for one reason or another, and it's maybe a little bit stubborn, or maybe you had an occluded site in my case, right?
Uh-huh.
Or you've had a high stress situation and you've been maybe out of range for a little while. You're having an injury or a stress, or you had a steroid shot. You maybe missed an insulin dose,
Yep.
or you've had some sort of interruption to your pump therapy. All of those are good opportunities to rule out ketones by using whatever testing methodology that you have. Is there anything else that you would recommend, like as a
Yeah.
patient is developing their ketone plan, their diabetic ketone action plan?
Yeah. I love what you talked about. I'm not walking around thinking all bad things are going to happen. We don't wear CGMs thinking we're going to have hypoglycemia every day, right? In fact, there's a point where we're going to be kind of let that particular thing go. But when do you wake up? Now, I want to bring up a really important part because I know some of our listeners are going to say this. Oh, I do have ketone strips, or I have a ketone meter, and I did check and it was negative, and every time I checked it was negative. Well, that's great. That doesn't mean that you're going to be negative in a different scenario. I want to know a few scenarios. And so, you know what? Maybe one of the things our listeners can do is say, think of the scenarios in my life. Well, what is it going to be? I'm on a pump. I haven't had steroids, so I'm not doing that. But it's those top of line, right? So maybe just pause and think, what are the scenarios that I have in my life that I'm going to be at risk for ketosis? And I'm going to do a DK assessment. I'm going to do an assessment to say, did I produce ketones in this scenario? Now, with the illness, it will vary. I have seen some illnesses that absolutely do not do anything related to cortisol and growth hormone. Don't change your insulin threshold needs. Don't create that resistance. That doesn't mean, because what do? We thump all illnesses in the same, because remember, bladder infection is bacteria. That could be totally different. You got a site that has an infection or an abscess, totally different. So in 6 scenarios, we're going to always check, right? Those are going to be kind of the low-hanging fruit. And high glucoses, we're going to check, but it doesn't have to be that way. Maybe every time you throw up, you're going to check. And if you want to do it like that, fine. Again, who cares? These are so inexpensive for the little urine ones. And yes, the finger pokes are a little bit more, but it's not just saying, well, I checked for ketones once, I'm good. Well, it's like that scenario. You don't just look at your speedometer one time in your whole life and say, well, I'm not speeding, I'm fine, right? No, it's something you get a cadence of, right? You're driving, you know how your car sounds, and you're looking at your speedometer like, I'm good. And so it's just look at it. Look at the speedometer, see where you're at, do that, ketone assessment, have that action plan, and tell me your story, because I'm just your clinician and you have your diabetes and I'm just your Sherpa going along for the ride.
You are the queen of diabetes metaphors, and I'm honored to be in your presence. One that you brought up in episode 1 of this series was the fuel gauge, and how when we look at our fuel gauge and it's half empty, we don't say, "Oh, I'm such an idiot for driving
Yeah,
and using
yeah.
my fuel."
Oh,
And I think that's what comes up for me with a negative ketone reading is, hey, it's good information. It means that I'm okay. It means that, hey, I
right
can
now.
okay for now, correct? So let's talk about that too, because again, back to your metaphors of fire and flood, like those situations and scenarios change extremely
Yep.
fast, and so can a situation with ketones. So let's just go down our checklist. Thankfully, we've got a plan. We talked about it with our care team. So we were feeling a little under the weather. We checked our ketones. Our glucose is a little bit high. We've got negative ketones on our first test.
Yeah, yeah, yeah.
3 to 4 hours later, though, we're still not feeling much better. Our glucose has been pretty stubborn. We're
Mhm.
still riding a little bit high. And the opportunity comes up, it enters into the back of our head. Maybe I should check my ketones again. And it's positive. So like talk about a little bit how those scenarios can change quickly, even if you've already tested maybe negative that same day for ketone.
Yeah. And I like that. And, it's really hard to kind of give even patients time, because we like time, right? 2 hours, 4 hours, that kind of thing. I would say probably that, of course, we're not going to, you give a shot of insulin, you don't check your blood sugar, how it's not coming down. And then you start rage bolusing and stuff. It's like, no, we do want some time to go by. You're ill. You kind of do that checklist. You take ketones. Way to go. You are way ahead of most people, persons with diabetes. And can you imagine if we were checking ketones when we should 100% of the time, like using our glucometer? We do a lot for preventing actual diabetic ketoacidosis. So, we check it and we go, okay, what do I need to do to feel healthy? What do I need to do? Maybe I need to lower my glucose. Maybe I need to get a little bit more fluids. How am I feeling? Have I eaten? Am I prolonged fasting? Those are just like health things, right? Those
Sure.
aren't really even medical advice. They're just health things. Then you mentioned something. Oh, my sugar's still high. That's another thing. Your sugar's still high. Then you start troubleshooting your pump, right? Or your injections, or you look at your vial. Oh my gosh, I did that the other day. I had a vial of insulin way back in the CRISPR and it was old. And I did not look at the date, right? I even make mistakes like that. So you troubleshoot that. You try, maybe you're going to check ketones again because you're like, you know what? It didn't come down. Now I'm at a different threshold, or I feel nauseated. I have different symptoms, right? That's that wildfire. You check again, then you have a different direction. It's like your ketone adventure. Where are we at now? Where am I out on the path? Have I taken it to, we can call it DEFCON level 1, level 2. Do I need to do something else because you're checking in? And so I usually kind of have that recheck of 2 to 4 hours. That's a reasonable, it's not really published, but it's kind of a reasonable time, letting insulin, fluid hydration, that kind of thing, and then recheck. And again, when you hit your threshold, that threshold is discussed between you and your provider of, now I got to go to step 3. What do I do? What's my action plan? What have you talked about? Where do I go? Where do I call? That kind of stuff.
I think that's my biggest takeaway really from the whole series is like, hey, the knowledge is power, and this is so variant, varies so much between people, and everyone's going to have a different response. And so it's really important for, at your next appointment with your endocrinologist, with your family medicine, with your CDCES, to develop and align on that plan of what is your threshold, what is your DEFCON 1, because it might be different for you than it is for somebody else. Making sure that you've got your home kit prepared, whether it's the blood test or it's the urine test, so that you can make decisions with like good data and keep yourself safe when diabetic ketoacidosis, comes around, or you're dealing with a situation where you're in a likely scenario where it could happen, and know when to call your doctor and know when to take yourself to the emergency room or to the urgent care, and having a plan aligned with your care team, and being proactive with that. I think that's where, again, back to the fire and the flood example is, you have, I think of a hotel, you have on the back of the door, there's a map of where to go in case of a fire. And it's very similar for, in case of DKA, here's my diabetic ketoacidosis action plan. And these are the steps that I take. One of the things that's really challenging when your glucose is out of range and you're under a lot of stress and you're worried is, you can start to swirl and you start to, be, confusion is another one of the symptoms of DKA. And so having a plan that's already written down and already agreed upon that you can just look at and follow, I think could come in really handy.
Rob, I think of 2 other things I want to add real quick because we haven't talked about it. Your loved ones, your care
Yes.
team, whether it's your care team or your family. Do you know, I think of this as well, as I have 2 girls, and one day I was walking through the airport and I was having a low blood sugar, and my kids turned to me and said, "Mom, check your blood sugar. I think you're low." And I'm like, "How do you know?" And they said, "You're just acting funny." And so even though many of us with diabetes don't want to be a burden, so we don't want to burden our family members and caregivers, I'm there with you, our own little solitary island, right? But sometimes even having that care plan with your family members for them to say, hey, if I'm puking, make sure that I'm checking my ketones. Because if you are confused, just like with low blood sugars, you're not always making the right decision. So it's nice to have kind of a backup quarterback come in and say, hey, I really want you to check your ketones. So share that with your loved ones. They really do love you. You're not a burden to them. They want to help you. And so if you're empowering them to empower you to say, hey, pee on the stick or whatever, I think it's also okay to do that, right? And sharing that plan with them. And then finally, we're talking such cutting edge here, Rob. Some of my clinician colleagues, God bless them, I love them, I educate them, there's some going to be listening. Many of them are still emerging with this ketosis plan. Think about it. We're not testing because many of my clinician colleagues are not prescribing. So it may be that you bring up a conversation with your clinician that might not be top of mind with them. It's
Sure.
okay. You can even say, hey, I saw this really cool podcast. You should check it out. It was really neat, kind of thing. But But it's okay that if your clinician may not be up to speed with this, because we are bringing cutting edge stuff here. And that's my job, is to educate colleagues too, because you know what? It is. We're a team. It's a shared. The person is at the center. And so it's okay to kind of educate your clinician as well, because they'll welcome it.
Well, I want to thank you for being part of our team and for bringing this really great information about a very serious topic in such a light and informative and entertaining way, especially as someone living with type 1 diabetes who can speak from both the care side and clinician side and the side of the patient, and for making this very serious topic a little bit lighter and a little bit more digestible and accessible. So thank you, Dr. Miller. And if you are only listening to this part, listen to part 1 and part 2 of Dr. Miller's interview on Diabetics Doing Things as well.